This is a very interesting question. To be honest, in the therapy of COPD, we have not a real advance, but we are understanding how to use better the drugs that we have in our hands. Now we know that likely COPD is not a disease, it's a disorder that includes a lot of different diseases or phenotypes as you prefer. We still do not understand very well because we must put together phenotypes and endotypes to understand if we have different diseases. But we know that there are specific phenotypes such as frequent exacerbators or such as emphysema, hyperinflation, or rapid decliners, or COPD with chronic bronchitis that need specific treatments, and each of these phenotypes need a tailored treatment. This is what we have understood, and we have also understood that we must not look at the COPD as a disease and treat all patients in the same manner, but we must look at the treatable trait in each patient, and in this manner we can try to improve our patients' quality of life and health condition, of course. As physician, I am using to combine drugs to treat COPD patients from a long time. Now what we have is the development of dual bronchodilation. That means to put together an antimuscarinic agent and a beta-2 agonist. Usually we try to put together once daily drugs or twice daily drugs. The combination is extremely useful because we have documented that there is a synergistic effect when you combine two bronchodilators. It means that potentially you could start with lower dosage that we are using now to optimize the bronchodilation, interfering with the vagal system, that is what regulates the bronchial tone, and adding the stimulation of beta-2 adrenal receptors that are extremely important to amplify the bronchodilation that you induce with antimuscarinic agent. And the synergistic effect means that we can reduce the dosage, and ideally, in my opinion, we should start to combine two drugs with the low dosage than, as I said before, we are using now for treating these patients. That's an extremely important point. There is an improvement also in devices. Technology is dramatically improved in these last 5 years, and I can see, speaking with the companies or attending meetings and so on, that there are new devices that are coming that will be even better than those we use. As clinical pharmacologist, I consider drugs extremely important, but I know that if we don't have a good manner to deliver drugs, drugs will never reach the highways of our patients in the right manner and the right amount. So devices are extremely important, and I say fortunately we have improved the devices, and we will have even better I think in 1 or 2 years. You will see. That's a extremely useful thing. It depends if you are asking me this as a physician or as a specialist. As a general practitioner, well, I can tell you that the general practitioner must follow guidelines and recommendations, must have a simple approach that can guarantee that the patient is at least treated. As specialist, as I said in my first answer, well, I must try to tailor the treatment according to the patient's needs. That's a problem. Yes, we have several new options now. New option in the sense that we have dual bronchodilation, we have triple therapy in development as well. We have different devices that can be adapted to the single patients, and I must always try to find the best treatment for each patient that I treat. I didn't mention before that we cannot forget that COPD is followed or is often followed by comorbidities, and we must always consider to treat also these comorbidities in the better manner, in the best manner, because otherwise we can improve lung function, we can reduce exacerbation, But for example, we can have a big problem with the heart or with diabetes and so on, and at the end the quality of life and the health of our patients will never improve.